As we've witnessed in this chapter, lots of bad things can happen to patients with diabetes in the long term. However, there are two acute complications of diabetes you need to watch out for as well. Diabetic ketoacidosis, or DKA, and hyperosmolar hyperglycemic state, or HHS. Each represents an extreme in the spectrum of hyperglycemia. Let's start with DKA. First, a little review of the pathophys. DKA occurs mostly in type 1 diabetes, though in rare cases, it occurs in type 2 as well. Type 1 diabetes, remember, is characterized by autoimmune destruction of pancreatic beta cells. This results in an absolute insulin deficiency and increased blood glucose. Insulin deficiency leads to glucagon excess, promoting a catabolic state, even further increasing blood glucose. Not to mention that glucocorticoids and catecholamines are ramped up in this state of stress, all leading to a catabolic state of hyperglycemia. In the setting of diabetes type 1, inadequate insulin administration or an acute infection can set off this train wreck of events, resulting in DKA. In the setting of DKA, serum glucose is over 200 milligrams per deciliter, often in the range of 300 to 500. Severe hyperglycemia causes glycosuria as the high serum levels of glucose exceed the renal glucose reabsorption capacity. This leads to an osmotic diuresis and severe volume depletion, one of the hallmarks of DKA. The other hallmark? Well, the ketoacidosis, of course. In the setting of decreased insulin, increased glucagon, and increased catecholamines, hormone sensitive lipase is activated, releasing triglycerides. These triglycerides provide the fuel for ketogenesis by the liver, a process for shunting more nutrients to the brain. Accumulation of beta hydroxybutyrate and acetoacetic acid in the serum contributes to a metabolic acidosis. And there you have it. Lots of blood glucose, lots of ketones, and lots of peeing causing hypovolemia. Next, we'll go over how to recognize it and what to do about it. First of all, the signs and symptoms of DKA develop rapidly, usually within 24 hours, conveyed by the rapid speed of that DKA car. And the young driver is there to remind you that DKA is more common in patients less than 65 years old. In known diabetics, DKA usually follows some type of precipitating event. This can be any type of stress or illness, most commonly an acute infection such as UTI or pneumonia, which is why we've added our recurring bacterial lanterns up in the stands. DKA can also be caused by inadequate insulin therapy. Ask about their normal insulin regimen at home, as well as any changes in regimen. Also ask about any other anti-diabetic medications. Assess for reasons the patient may be undertreated with insulin. Some patients may omit insulin in the setting of GI illness and reduced oral intake, for example. Or there may be a psychological reason for skipping doses, such as eating disorders or fear of weight gain. Some patients have an insulin pump, which can malfunction, though pump malfunction is uncommon. Also, it's important to keep in mind that DKA is a common presentation of new onset type 1 diabetes. When you start your rapid fire interrogation about the patient's home insulin regimen, she'll probably respond, "What's insulin?" Patients with DKA present with polydipsia and polyuria from severe hyperglycemia. Remember that whole osmotic diuresis thing we talked about earlier? Increased urine output leads to dehydration and excessive thirst follows. Patients with DKA can also present with nausea, vomiting, and abdominal pain, possibly due to ileus or a few of the electrolyte abnormalities we'll talk about in a second. DKA can cause altered consciousness, such as lethargy, as a result of severe acidosis. More severe altered consciousness, such as obtundation and coma, may be seen if serum osmolality is severely elevated, but this is less frequent in DKA. Alright, let's get those vitals. The vital signs of patients with DKA will reflect a state of volume depletion, such as tachycardia and orthostatic hypotension. Hence the dry pretzel there with the tachycardic watch and fainting flagman. Additionally, Patients with DKA may exhibit abnormally rapid and deep breathing, known as Kussmaul respiration. This reflects respiratory compensation for the underlying ketoacidosis. Next, a few key physical exam findings. First of all, you may notice a fruity odor as a result of exhaled acetone. At Sketchy, we symbolize the fruity smell of acetone with a newly opened box of scented sweet ones. Also, expect to see signs of dehydration, including dry mucous membranes and decreased skin turgor. Dry as a pretzel, in other words. Next up, labs. Start with the fingerstick glucose, which can be obtained in seconds and can establish a provisional diagnosis if severe hyperglycemia is present. As we discussed, DKA presents with hyperglycemia, which is a serum glucose greater than 250 milligrams per deciliter. Levels are often in the 350 to 500 range, but rarely increase above 800 milligrams per deciliter. Positive ketones are a key feature of DKA. Urine ketones are usually tested first with a nitroprusside test, which detects acetoacetate and, to a lesser degree, acetone in the urine. Acetoacetic acid is symbolized by the sweet acid box, and of course, sweet smelling acetone is symbolized by that sweet ones box. Both boxes are yellow because these are the ones you'll see in the urine. If positive, serum ketones are then measured. In DKA, beta hydroxybutyrate is usually the predominant ketone in the blood. Beta hydroxybutyrate is symbolized by this big chew bubblegum box, red because it's found in the blood. Patients with DKA also develop a high anion gap metabolic acidosis. All those keto acids are the unmeasured anions that contribute to the gap. An ABG will confirm acidosis, with a pH usually less than 7.3 and a serum bicarb less than 18. In DKA, total body potassium is low, mostly as a result of urinary losses due to osmotic diuresis and excretion with keto acid anions. This is represented by the empty banana frosting container. However, the serum potassium concentration is usually normal or elevated. This is an effect of insulin deficiency and hyperosmolality, both of which cause a potassium shift from the intracellular compartment to the extracellular compartment. That's why we've drawn the frosting elevated outside, even though it's empty on the inside. In DKA, total body phosphate is usually low as a result of osmotic diuresis. Phosphate should be repleted only if it's severely low, less than 1 milligram per deciliter, in other words. Routine phosphate repletion, however, is not recommended. Most patients with DKA have mild hyponatremia, though serum sodium level may be low, normal, or elevated depending on the patient's ability to replenish urinary fluid losses. Regardless, be aware that the serum sodium reported on your lab report is lower than it should be. Severe hyperglycemia drives water out of the intracellular compartment into the extracellular compartment, thus diluting your serum sodium. A corrected sodium concentration can be calculated by adding 2 milliequivalents per liter to the sodium concentration for each 100 milligram increase in serum glucose over a baseline glucose of 100. This will provide a rough estimate of how much the serum sodium concentration will rise as you correct the hyperglycemia. So, you think your patient might have DKA? Well, before you start an insulin infusion, let's briefly talk about what else should be on your differential. Briefly, the two main conditions you should rule out when you're considering DKA are other causes of ketoacidosis and other causes of anion gap metabolic acidosis. Ketoacidosis can also occur in the setting of fasting ketosis and alcoholic ketoacidosis. The ketoacidosis during fasting or low carbohydrate diets is usually mild. Alcoholic ketoacidosis, on the other hand, occurs in malnourished alcoholics after an episode of binge drinking. Blood alcohol levels may be undetectable at presentation because ketone body formation occurs after a sudden cessation in drinking, and ethanol levels have already fallen. One of the pathways of ethanol metabolism is to acetyl-CoA, which can be used for ketone production, especially in a state of malnourishment. So these patients will have ketoacidosis, but characteristically will not have hyperglycemia. Of note, in patients with alcoholic ketoacidosis, acetoacetate is converted to beta hydroxybutyrate. So, to detect ketosis, it's important to use serum hydroxybutyrate instead of urine acetoacetate levels. Next on our DDX are causes of anion gap metabolic acidosis. Yep, the old mud piles mnemonic. The distinguishing factor with these is that none cause ketosis, but they can coexist in a person with DKA, so they must be ruled out. All right, let's do a brief patient presentation summing up the important information so far. Mr. Heath is a 20-year-old man with type 1 diabetes who presents with nausea, vomiting, and abdominal pain for the past 3 hours. He has not eaten or taken his insulin since last night, when he had multiple episodes of diarrhea and abdominal cramps. His home insulin regimen is 40 units of insulin glargine daily and 12 units of Lispro before each meal. Vitals are significant for a heart rate of 150 and a respiratory rate of 25. Physical exam is notable for fruity breath, dry mucous membranes, and deep inspirations. Labs on arrival are significant for a glucose of 400, pH of 7.2, and bicarb of 16. Dipstick UA shows significantly elevated ketones. Based on Mr. Heath's history, presentation, and labs, I'm most concerned for diabetic ketoacidosis. Once a presumptive diagnosis of DKA is made, immediately begin IV fluids to correct the hypovolemia. Fluid repletion is initiated with isotonic 0.9% saline. That's why this jelly bean mechanic is topping off that engine with NS motor oil. That's NS for normal saline, the number one name in resuscitation. See how this next tank is full? It looks like we've repleted the volume. Now what? Well, once the intravascular volume is restored after 2 or 3 hours of fluid administration, isotonic saline can be switched to 1/2 isotonic saline only if the corrected serum sodium concentration remains normal or elevated. In other words, if we do that corrected sodium equation that we learned earlier and we calculate a normal or increased serum sodium concentration, it's safe to begin administering even more dilute fluids. Half normal saline, that is. However, if their corrected sodium is low, then better keep that normal saline running. Recall that regardless of the initial measured serum potassium, total body potassium is low. Once insulin is given, expect potassium to shift back into cells, which may lead to hypokalemia. Potassium should be replaced without delay using IV potassium chloride if initial serum potassium is less than 5.3. If initial potassium is higher, that's great, but be proactive. Begin replacement once potassium falls below 5.3 at any point during treatment. Along with potassium as needed, IV regular insulin should be started immediately. Regular insulin is administered as a continuous IV infusion. Sometimes a bolus dose is given first. And another warning to all you kids out there. If initial serum potassium is below 3.3, do not administer insulin yet. Replete the potassium until it's above 3.3. An insulin induced potassium shift in the setting of pre existing hypokalemia can cause dangerously low, lethal arrhythmia generating serum potassium. See that egg with a regular surprise inside? It represents IV regular insulin, which should be started immediately. Guess we better read the warning label first, though. Not for kids less than 3.3. That's oddly specific. In other words, if the potassium is less than 3.3 milliequivalents per liter, insulin is withheld until potassium is above 3.3. For patients with severe acidosis with an arterial pH less than 6.9, some clinicians recommend giving sodium bicarbonate to help correct the acidosis. Sodium bicarbonate is not recommended for less severe acidosis. So, peeking into the scene, we've brought in our recurring bicar race car. Just a little reminder. Alright, so how do we know all these treatments for DKA are working? We monitor for improvement in ketoacidosis using the serum anion gap. We can also do a direct assay of beta hydroxybutyrate, the major serum ketone in DKA. So notice that we have a spectator up here monitoring the race. We've placed him next to the anion gap as well as the red BHB box. Closure of the serum anion gap indirectly indicates that the ketoacidosis has resolved. Be aware that urinary or serum ketone levels are often measured using the nitroprusside method, which tests for the presence of acetoacetate, not beta hydroxybutyrate. The nitroprusside method can be used for initial diagnosis of ketoacidosis, but should not be used for monitoring. Nothing like the satisfying crunch of dextrose. Part of a balanced DKA regimen. Add 5% dextrose to the IV fluids once the blood glucose reaches 200 milligrams per deciliter to avoid overshooting into hypoglycemia. Notice the 200 incorporated into the side of the car there. Once the blood glucose is less than 200 milligrams per deciliter, the anion gap closes and the patient can eat. The IV insulin infusion can be tapered and a sub-Q insulin regimen started. The sub-Q and IV insulin should be overlapped by 1 to 2 hours. In patients with known diabetes, their home insulin regimen can be restarted. For patients with a new diagnosis of diabetes, a weight based regimen is established starting at a dose of zero point 0.5 to zero point 0.8 units per kilogram per day. Ah, we did it! We saved our DKA patient. Time to discuss the other version of the story: hyperosmolar hyperglycemic state, or HHS. It's symbolized by this wreck on the side of the track with that HHS steam. HHS is seen primarily in elderly patients with type 2 diabetes. Type 2 diabetes, remember, involves a relative insulin deficiency, a state of insulin resistance, if you will, with some preserved beta cell function. Therefore, in HHS, ketogenesis and acidosis are minimal, as a small amount of insulin is able to blunt the release of counterregulatory hormones such as glucagon. As a small amount of insulin is able to blunt the release of counterregulatory hormones such as glucagon. The hallmark of HHS is, instead, super high serum glucose levels and super high serum osmolality. And golly, that is a super high 1 grand bar. Just look at it. Severe hyperglycemia causes glycosuria as the high serum levels of glucose exceed the renal glucose reabsorption capacity. This leads to an osmotic diuresis and severe volume depletion, the other hallmark of HHS. Yup, that tank is running on empty. In HHS, symptoms may develop more insidiously, often persisting for several days or even weeks before hospital admission. HHS is more common in older and or debilitated patients who are unable to access sufficient water. Serum glucose and osmolality rise to severe levels as patients are unable to replace the free water lost in the urine because of osmotic diuresis. Like in DKA, patients with HHS present with polydipsia and polyuria from severe hyperglycemia. Abdominal pain is not a feature of HHS. HHS commonly presents with mental obtundation or coma as a result of severe hyperosmolality, which is why this cracked brain helmet is floating in the conned Osm mints. Focal neurologic signs and seizures may also be seen. Like DKA, HHS usually follows some kind of precipitating event. This can be any type of stress or illness, most commonly an acute infection. It can also be caused by inadequate insulin therapy. Patients with HHS present with vital signs consistent with hypovolemia, including tachycardia and orthostatic hypotension, again, symbolized by the fainting tachycardic flagman in the center there. Also expect to see signs of dehydration, including dry mucous membranes and decreased skin turgor. Yup, as dry as a pretzel. Severe hyperglycemia is a key feature of HHS. Levels are typically higher than 600 milligrams per deciliter, but often exceed 1,000 milligrams per deciliter. Unlike DKA, HHS does not present with ketoacidosis. pH and bicarbonate are normal or only slightly reduced, and there's little to no ketones in the serum or urine. Elevated plasma osmolality is another key laboratory feature in HHS. This is a consequence of the severely elevated serum glucose. The effective plasma osmolality is typically greater than 320 milliosmoles per liter. Effective plasma osmolality is the portion of total osmolality that's generated by sodium and glucose. It's estimated by adding the sodium concentration times 2 to the plasma glucose divided by 18. As in DKA, in HHS, total body potassium is low, mostly as a result of urinary losses. However, the serum potassium concentration may be initially normal or elevated. This is a result of potassium shifting from the intracellular to extracellular space in the setting of hyperosmolality and insulin deficiency. The total body phosphate is usually low as well as a result of osmotic diuresis. Phosphate should be repleted only if it's severely low. And finally, just like we saw with DKA, most patients with HHS have a mild hyponatremia. Though serum sodium level may be low, normal, or elevated depending on the patient's ability to replenish urinary fluid losses. Regardless, be aware that the serum sodium reported on your lab report is lower than it should be. Severe hyperglycemia drives water out of the intracellular compartment into the extracellular compartment, thus diluting your serum sodium. A corrected sodium concentration can be calculated by adding 2 milliequivalents per liter to the sodium concentration for each 100 milligram increase in serum glucose over a baseline glucose of 100. This will provide a rough estimate of how much the serum sodium concentration will rise as you correct the hyperglycemia. Let's summarize the presentation of HHS in a sample assessment statement. Mrs. H. Smith is a 70-year-old woman with type 2 diabetes who was brought in from her nursing home with 1 week of worsening restlessness and confusion. She was diagnosed with pneumonia 2 weeks ago and was prescribed a week of doxycycline. Her current medications include metformin only. Vitals are significant for a heart rate of 140 and orthostatic hypotension. Labs on arrival were significant for a glucose of 1200, pH of 7.36, and a bicarb of 26. Dipstick UA was unremarkable. Given Mrs. Smith's medical history, her current presentation and labs are concerning for hyperosmolar hyperglycemic state. Management of HHS is very similar to that of DKA, so we'll just provide a brief rundown here. For more details, check out the DKA management section of the video. In general, patients with HHS need immediate fluid repletion with isotonic saline, proactive potassium repletion if under 5.3, and infusion of IV regular insulin. Potassium less than 3.3 must be repleted first before insulin is started. Once the blood glucose is under 200, you can add 5% dextrose to the IV fluids. Once the blood glucose is 250 to 300 milligrams per deciliter and the patient can eat, the IV insulin infusion can be tapered and a sub-Q insulin regimen is started. You know the treatment is working when we see those effective plasma osms come down and the mental status return to normal, which is a reflection of the improved serum osmolality. So we've got Sean over here monitoring this HHS rack next to the conned osments and the broken brain helmet. What a nail biter! DKA and HHS were neck and neck the entire time. Let's wrap up this sketch with a brief summary of what we've learned. DKA is primarily a complication of type 1 diabetes and is characterized by hyperglycemia in the range of 300 to 500, dehydration secondary to osmotic diuresis, and ketoacidosis. Clinically, DKA typically presents with acute onset of polyuria, polydipsia, nausea, vomiting, and altered mental status, often triggered by a precipitating event such as infection or inadequate insulin therapy. Often, DKA can be the initial presentation of previously undiagnosed type 1 diabetes. So don't assume it's not DKA just because your patient doesn't have a diagnosis of diabetes. On exam, look for those characteristic rapid, deep Kussmaul respirations and the unique fruity breath indicative of ketosis. In addition to elevated glucose levels, usually in the 300 to 500 range, patients with DKA will also have positive urine and serum ketone levels, as well as anion gap metabolic acidosis on ABG. Interestingly, patients will have hyperkalemia despite having low total body potassium as a result of insulin deficiency shifting potassium out of cells. Meanwhile, dilutional hyponatremia will occur due to hyperglycemia-induced hypertonicity. Remember these weird serum electrolyte abnormalities since people love to ask questions about them. Initial management of DKA focuses on two things: fluid resuscitation, primarily with normal saline, to treat dehydration, and IV regular insulin to bring glucose levels down. Remember to keep an eye on serum sodium, potassium, and pH levels during treatment, and tweak your management to address these issues if they come up. In the end, you'll know you're done treating DKA when the patient's ketoacidosis resolves and glucose falls below 200. At that point, you're free to switch over to normal sub-Q insulin and get the patient ready for discharge. Hyperosmolar hyperglycemic state, on the other hand, occurs almost exclusively in patients with type 2 diabetes, and elderly ones in particular. Just like DKA, HHS is associated with significant dehydration from osmotic diuresis. However, unlike DKA, blood glucose levels in HHS tend to be much higher. We're talking above 1,000. HHS tends to present more slowly than DKA, although with many of the same symptoms, such as polydipsia, polyuria, and altered mental status, again, typically triggered by an insult like infection or inadequate insulin therapy. In addition to, or because of, super high blood glucose levels, effective plasma osmolality is elevated as well. Similar to DKA, a number of electrolyte derangements are common in HHS, including hyperkalemia despite low total body potassium, hypophosphatemia due to osmotic diuresis, and dilutional hyponatremia. However, the one thing you will not see in HHS is ketoacidosis. Treatment wise, HHS is managed in much the same way as DKA: IV normal saline to treat dehydration, and IV regular insulin to treat hyperglycemia. Fix the electrolyte abnormalities as necessary, and transition to outpatient diabetes therapies once you see plasma osmolality and mental status return to normal. Well, that about does it for us here at the Candy Track. Check out the rest of this chapter for all the details you'll need on diabetes.